Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 426 of our pharmacotherapy series, which majors in adverse effects of chemotherapy and targeted agents. The next case reads, SGR, a 58-year-old man with metastatic colorectal cancer, previously progressed after 4 cycles of FOLFOX, that is, oxaliplatin dosed at 85 mg per meter squared IV on day 1, leucovorin 100 mg per meter squared IV on days 1 and 2, and fluorouracil 400 mg per meter squared IV bolus, followed by 600 mg per meter squared IV for 22 hours on days 1 and 2, plus bevacizumab dosed at 5 mg per kilogram. He also recently progressed after 2 cycles of second-line FOLFIRI, that is irinotecan 180 mg per meter squared on day 1, leucovorin 100 mg per meter squared IV on days 1 and 2, and fluorouracil 400 mg per meter squared IV bolus, followed by 600 mg per meter squared IV for 22 hours on days 1 and 2. SGR now presents to the clinic for his first weekly dose of cetuximab, 400 mg per square meter IV load, followed by 250 mg per meter squared IV weekly. I would like you to discuss the toxicities that SGR may expect and when they might appear. How should these side effects be managed? SGR asks how these side effects can be prevented. The most common toxicities observed in patients receiving cetuximab include rash, diarrhea, hypomagnesemia, headache, nausea, and hypersensitivity reactions. Infusion-related reactions occur in 15% to 20% of patients receiving their first infusion. However, severe hypersensitivity reactions, including allergic and anaphylactic reactions, occur in 1% to 3% of patients. The reactions are related to the infusion of cetuximab and generally occur during or within 1 hour of completing the first dose. Patients should be pre-medicated with diphenhydramine before the infusion. The infusion can be stopped or the rate decreased if SGR begins experiencing these effects. The skin rash and dry skin occurring after cetuximab administration are related to the inhibition of epidermal growth factor receptor and were the most common side effect seen in clinical trials. The rash occurred in approximately 80% of patients and appeared in the first 1 to 3 weeks of therapy. Grade 3 or 4 skin rashes occurred in 5% to 10% of patients. Several of the monoclonal antibodies, e.g., rituximab, trastuzumab, cetuximab, ofatumumab, are associated with a higher incidence of hypersensitivity reactions than traditional cytotoxic agents. These agents are genetically engineered humanized monoclonal antibodies containing foreign proteins that can trigger the reaction. During the first infusion with trastuzumab, approximately 40% of patients experience a symptom complex, mild to moderate in severity, which consists of chills, fever, or both. These symptoms usually do not recur with subsequent injections. In comparison, approximately 80% of patients receiving rituximab may experience an infusion-related reaction ranging from fever, chills, and rigors to severe reactions, 7%, characterized by hypoxia, pulmonary infiltrates, adult respiratory distress syndrome, myocardial infarction, ventricular fibrillation, or cardiogenic shock with the first dose. Approximately 40% of patients receiving rituximab experience infusion-related reactions with subsequent infusions, that is 5% to 10% severe. Treatment of these reactions follows the recommendations for treatment of hypersensitivity reactions that occur with more traditional agents. If a patient experiences a severe type 1 hypersensitivity reaction to any anti-cancer agent, the treatment should be stopped. If a structural analog or another agent in the same chemical class is an effective treatment for the same cancer, subsequent therapy should use the analog or other agent to minimize the risk of future reactions. If the reaction is mild or moderate, the patient may continue with the same therapy if treatment is preceded by methods to prevent or minimize hypersensitivity reactions. Pre-treatment with corticosteroids and diphenhydramine significantly decreases the frequency and severity of hypersensitivity reactions. However, the effect of H2 receptor antagonists and epinephrine remains controversial. Because the success of these preventive measures depends on the cause of the reaction, that is immunologic or anaphylactoid, the aforementioned characteristics of type 1 reactions should be used to assess the underlying pathogenesis. In addition, other chemicals present in the formulation or other agents administered concomitantly with the chemotherapy can cause the hypersensitivity reaction. Potential allergens included in the diluent or formulation of chemotherapy agents include CRUMA4-EL, which is present in paclitaxel, polysorbate 80, which is present in docetaxel and etoposide, benzyl alcohol, which is present in the parenteral form of methotrexate, cytarabine, and etoposide, and methoxy-polyethylene glycol, which is present in liposomal doxorubicin. Recognizing potential allergens can significantly affect treatment of the current reaction and minimize the risk of future reactions. To reduce the hypersensitivity reactions observed with paclitaxel protein-bound particles, e.g. Abraxane, an albumin-bound formulation of paclitaxel, has been created. Because paclitaxel protein-bound particles formulation is CRUMA4-EL free and less likely to cause hypersensitivity than traditional paclitaxel, it is not necessary to pre-medicate patients with steroids and antihistamines. Doses between the two agents are not comparable. Although fewer hypersensitivity reactions are associated with this formulation, myelosuppression remains a dose-limiting toxicity. The next case reads, TAL, a 39-year-old woman with acute lymphocytic leukemia, has been admitted to the hospital for induction chemotherapy. Methotrexate dosed at 3 grams per meter squared IV once on day 1, cytarabine dosed at 2 grams per meter squared IV every 12 hours on days 2 and 3 for 4 doses, vincristine 2 mg IV on days 1 and 8 for 2 doses, and dexamethasone 20 mg orally daily for on days 1 through 5 are ordered. Laboratory data obtained on admission include a WBC count of 120,000 cells per microliter, with 9% neutrophils, 11% lymphocytes, and 80% blasts. On day 3, TAL is confused and she has difficulty performing a finger-to-nose neurologic examination. On day 10, she complains of numbness in her hands and feet. In addition, the clinician notes an eyelid lag and ataxia. TAL also complains of severe constipation. So my questions to you are as follows. What signs and symptoms of neurotoxicity is TAL experiencing? Should the leukemia regimen be modified for future courses? We will briefly look at methotrexate, cytarabine, and vincristine. Methotrexate causes little or no neurotoxicity when administered orally or intravenously in doses less than 1 gram per meter squared. However, high-dose IV methotrexate, usually above 1 gram per meter squared, can occasionally cause acute encephalopathy. The encephalopathy that occurs after therapy with methotrexate is usually transient and reversible. Some patients may experience a progressive leukoencephalopathy after high-dose IV methotrexate. The risk of leukoencephalopathy increases with higher cumulative doses of methotrexate and concomitant cranial radiation therapy. Posterior reversible encephalopathy syndrome has also been associated with high-dose methotrexate and intrathecal methotrexate. Chemical meningitis can occur with intrathecal administration of methotrexate and, less frequently, myelopathy or paraplegia may be observed. Patients receiving intrathecal therapy or high-dose methotrexate should be carefully monitored for signs and symptoms associated with neurotoxicity. High doses of cytarabine, that is above 1 gram per meter squared in multiple doses, are associated with CNS toxicity in 8% to 37% of patients. These neurotoxicities are dose-related and schedule-related. Doses greater than 18 grams per meter squared per course increase the frequency of neurotoxicity. Older patients are more susceptible than younger patients, and the prevalence seems higher in subsequent versus initial courses of therapy. As illustrated by TAL, neurotoxicity may become evident within a few days after treatment with cytarabine and, most commonly, the neurotoxicity is manifested by a generalized encephalopathy with symptoms such as confusion, obtundation, seizures, and coma. Cerebellar dysfunction, presenting as ataxia, gait and coordination difficulties, and dysmetria, inability to arrest muscular movement when desired and lack of harmonious action between muscles when executing voluntary movement, is also commonly observed in patients receiving high-dose cytarabine therapy. These neurologic symptoms may partially resolve over days to weeks after discontinuation of therapy. Other neurologic toxicities reported with cytarabine include progressive leukoencephalopathy and chemical meningitis. Intrathecal administration of cytarabine, including the liposomal formulation, may also cause a chemical meningitis or arachnoiditis. Leukoencephalopathy typically presents with progressive personality and intellectual decline, dementia, hemiparesis, and, sometimes, seizures. These neurotoxicities also can occur after treatment with other chemotherapy agents. Asparaginase and PEG asparagine can cause encephalopathy, which presents most commonly as lethargy and confusion. These agents are used in acute lymphocytic leukemia regimens. Severe cerebral dysfunction occurs occasionally, and patients may present with stupor, coma, excessive somnolence, disorientation, hallucination, or severe depression. Symptoms can occur early, within days of administration of asparaginase, or late, depending on the treatment schedule. The suspected mechanism is the direct neurocytotoxic effect of aspartic acid, glutamic acid, and ammonia. The neurotoxicity is usually reversible, with the acute syndrome clearing rapidly and a delayed syndrome lasting several weeks. TAL's symptoms most likely are the result of CNS toxicity caused by both high-dose methotrexate and cytarabine. A decision regarding further treatment with these agents is complicated because omitting a dose or decreasing the dose of either of these agents could compromise the likelihood of a complete remission. High-dose cytarabine cerebellar toxicity may be irreversible. Therefore, the clinician may decide to discontinue cytarabine in TAL's future regimens. Additionally, modifications of methotrexate, including dose reductions, may be necessary in future therapy for TAL. Multiple other anti-cancer agents, including fluorouracil, fludarabine, nelarabine, procarbazine, and ifosfamide, produce an encephalopathic toxicity. Recognition of neurotoxicity resulting from cytotoxic chemotherapy is often difficult because of comorbid conditions such as metastatic disease and other paraneoplastic syndromes, but it is important in assessing the need for potential dose modifications or even discontinuation of the agent. Several reviews provide detailed explanations of signs and symptoms, mechanisms, and potential treatments for chemotherapy-induced neurotoxicities. When a patient presents with any signs or symptoms of neurotoxicity, the patient should receive a neurologic examination followed by a dose reduction or discontinuation of therapy. We will now briefly look at fluorouracil. Fluorouracil can cause acute cerebellar dysfunction characterized by the rapid onset of gait ataxia, limb incoordination, dysarthria, and nystagmus. Cerebellar dysfunction occurs in approximately 5% to 10% of patients receiving fluorouracil at all treatment schedules in common use and can present weeks to months after beginning therapy. A more diffuse encephalopathy presenting as headache, confusion, disorientation, lethargy, and seizures can also occur. These symptoms can be reversed if fluorouracil is discontinued or the dose is reduced. Reports of cerebellar ataxia have also been reported with carpacetarbine, an oral prodrug of fluorouracil. Next we will consider fludarabine and nelarabine. Fludarabine can cause severe neurotoxicity when used at doses greater than 90 mg per meter squared for 5 to 7 days. Symptoms include altered mental status, photophobia, amaurosis, that is blindness that usually is temporary without change in the eye itself, generalized seizures, spastic or flaccid paralysis, quadriparesis, and coma. Patients may progress to death, even when therapy is discontinued. This neurotoxicity, however, is not common with the current recommended dosage of 20 to 30 mg per meter squared per day for 5 days. Mild neurologic symptoms are typically reported, but severe neurotoxicity and optic demyelination occurs only occasionally. Patients with signs or symptoms suggestive of significant neurotoxicity should receive a neurologic examination and, if warranted, therapy should be discontinued without re-challenging with a dose reduction. Nelarabine, another purine analog, has dose-limiting neurotoxicity, and 18% to 37% of patients in Phase 2 trials showed severe Grade 3 or 4 neurotoxicities. The clinical presentation includes severe somnolence, convulsions, and peripheral neuropathy ranging from paresthesias to motor weakness. Several cases of ascending peripheral neuropathies and demyelination have been reported. Therapy should be stopped if grade 2 toxicity is present, because some cases have been irreversible. Ifosfamide is associated with an encephalopathy thought to result from one of its metabolites, chloroacetaldehyde. The incidence ranges from 10% to 20%. It presents hours to days after initiation of treatment with confusion and disorientation and is generally self-limiting. Methylene blue, albumin, and thiamine have been used for both prevention and treatment. Conclusive evidence to promote routine prophylaxis is not available. Reported risk factors for this complication include a history of ifosfamide-induced encephalopathy, prior cisplatin exposure, concomitant opioids, concomitant CYP2B6 inhibitors, renal dysfunction, low serum albumin, increased hemoglobin, and abdominal disease. My next question to you reads: what is the most likely medication causing TAL's numbness? Regarding peripheral neuropathy, paresthesia, manifesting as numbness and tingling, involving the feet and/or hands is an early subjective symptom of vincristine neurotoxicity, which often appears within the first days to weeks of therapy. Because TAL received vincristine on days 1 and 8, it is reasonable to assume that her presentation of numbness in her extremities is secondary to her vincristine. This peripheral nerve toxicity commonly is bilateral and symmetric and is often referred to as a stocking glove neuropathy. Symptoms initially consist of paresthesias, loss of ankle jerks, and depression of deep tendon reflexes. Areflexia, that is absent reflexes, typically occurs in about 50% to 70% of patients treated with a cumulative dose greater than 6 to 8 mg. Although older patients appear to be more susceptible to paresthesias than younger ones, almost all complain of paresthesias after combination chemotherapy that incorporates vincristine or vinblastine. Pain and temperature sensory loss are usually more pronounced than vibration and proprioception sensory loss. Patients also may display motor weakness with a foot drop or muscle atrophy. Motor weakness, which can become the most disabling symptom associated with vincristine neurotoxicity, can occasionally cause muscle wasting. Although some patients exhibit muscle atrophy, true muscle weakness seldom occurs after treatment with vincristine. Stumbling and falling that can occur with this peripheral neuropathy is not usually caused by muscle weakness. Instead, it occurs in the dark when patients lose proprioception because they lack visual orientation. These complications are either partially or completely reversible, but recovery often takes several months. Other agents that often share the peripheral nerve toxicity of vincristine include vinblastine, vinorelbane, cisplatin, etoposide, oxaliplatin, paclitaxel, docetaxel, cabazitaxel, ixabepilon, bortezomib, thalidomide, and lenalidomide among others. Unlike the vinca alkaloids, most of these agents cause numbness only and not a loss of reflexes or weakness. Patients may report sensory loss and pain, however. The incidence may be related to cumulative doses as well as individual risk factors such as history of diabetic neuropathy. Many preventive strategies have been evaluated, including amifostane, glutamine, glutathione, vitamin E, and others, but many of the studies are limited by small sample sizes and are lacking placebo-controlled randomized designs. The serotonin norepinephrine reuptake inhibitor, abbreviated as SNRI, venlafaxine, was evaluated for the prevention of neuropathy in a randomized, double-blind, placebo-controlled Phase 3 trial of 48 patients receiving an oxaliplatin-based regimen. The primary endpoint was the percentage of patients with no acute neurotoxicity, which was significantly higher in the venlafaxine-treated group compared with patients receiving placebo, 31.3% versus 5.3%, respectively, with a p-value equal to 0.03. Due to the small study population and ongoing concerns about compromise of chemotherapy efficacy, this preventive strategy is not routine practice. Treatment strategies are only palliative and include adjuvant pain medications such as tricyclic antidepressants, anticonvulsants, pregabalin and gabapentin, and topical agents. Peripheral neuropathy is usually reversible, although resolution may take months. Several reviews provide detailed references for this information. Oxaliplatin causes peripheral neuropathies that differ from other anti-cancer agents. Oxaliplatin-induced neurotoxicity manifests as an acute neurosensory complex as well as a cumulative sensory neuropathy. Hyperexcitability of peripheral nerves causes an 85% to 95% incidence of paresthesia and dysesthesias of the hands, feet, and the perioral region. Laryngeal dysesthesias have been described as well. These effects are precipitated by exposure to cold. The cumulative dose-limiting chronic neuropathy is described as a sensory neuropathy that is reversible several months after completion of therapy. Dose modifications for patients with persistent neurotoxicities have been developed and typically involves delaying therapy until their condition improves. Prevention of these toxicities with infusions of magnesium and calcium has been evaluated in a prospective, randomized double-blind study of patients, n equal to 102, with colon cancer receiving adjuvant therapy with oxaliplatin, fluorouracil, and leucovorin. Patients received either calcium gluconate 1 gram IV and magnesium sulfate 1 gram IV 15 minutes before and immediately after completion of the oxaliplatin administration or placebo infusions. Calcium and magnesium infusions reduced the incidence of grade 2 of greater sensory neurotoxicities significantly over placebo, that is 22% versus 41%, respectively. An additional Phase 3 randomized trial of 353 patients randomly assigned to receive calcium and magnesium pre- and post-oxaliplatin showed no statistically significant differences in the incidence of peripheral neuropathy compared to placebo. Decreased efficacy of this anti-cancer regimen has been reported with use of the calcium and magnesium infusions. Therefore, the use of calcium and magnesium infusions remains controversial. My next question to you reads: what is the significance of TAL's lid lag? We will briefly discuss cranial nerve toxicity. Cranial nerve toxicity occurs in 1% to 10% of patients receiving vinca alkaloids, and most patients present with ptosis or ophthalmoplegia probably related to damage to the third cranial nerve. Toxicity to other cranial nerves can cause trigeminal neuralgia, facial palsy, depressed corneal reflexes, and vocal cord paralysis, and may occur in the first few days to weeks after administration. Other nerve toxicities associated with the vinca alkaloids include jaw pain, which can occur as early as after the first or second injection. The pain usually resolves spontaneously and does not recur with subsequent doses. Several of the cranial nerve toxicities, especially with vincristine, may be dose-limiting because evidence shows an increased prevalence with increasing doses. TAL's eyelid lag probably is caused by vincristine. Ifosfamide, vinblastine, and cisplatin have been reported to cause cranial neuropathies. Intra-arterial administration of chemotherapy agents such as carmustine may increase the risk of encephalopathy and cranial neuropathies. Ototoxicity, characterized by a progressive, high-frequency, sensorineural hearing loss, commonly occurs with cisplatin, most likely as a result of a direct toxic effect on the cochlea. Ototoxicity occurs more frequently at higher dosages, worsens with concurrent cranial radiation therapy, and appears to be more pronounced in children. The reversibility of cisplatin ototoxicity is questionable. At some centers, routine audiometric tests are performed in patients receiving cisplatin. As a result, these centers have a greater percentage of patients with documented decreases in audio acuity than others. Early cessation of cisplatin may result in greater hearing improvement. Although ototoxicity appears to be a major toxicity associated with cisplatin, it has been reported in patients receiving carboplatin. If ototoxicity is suspected, a hearing test should be performed and therapy discontinued if alternate treatments are available. Vincristine, as well as vinblastine, commonly causes an autonomic neuropathy. The earliest symptoms, manifesting as colicky abdominal pain with or without constipation, are reported by 1/3 to 1/2 of patients receiving these agents. Because severe constipation can progress to or include adynamic ileus, prophylactic laxatives are recommended on a regular basis for patients receiving vincristine and vinblastine. Stimulant laxatives such as the senna derivatives or bisacodyl are believed to be the most effective agents, and stool softeners also may be used concurrently. No compelling evidence suggests, however, that laxatives prevent constipation. Other less frequent manifestations of autonomic dysfunction associated with vinca alkaloids include bladder atony with urinary retention, impotence, and orthostatic hypotension. Patients should be monitored carefully for these signs or symptoms and receive appropriate management after diagnosis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 427.